Good morning, ladies and gentlemen. First of all, I'd like to thank Dr. Balavenkat and the organizing committee for inviting me to the Ganga Anesthesia refresher course this year. I feel really honored and privileged to be part of this program and the conference. I'm asked to talk about ultrasound for regional anesthesia and give an update. Based on the survey, I know some of you are already using ultrasound and some of you are not. So what I hope to do today is to go over some of the fairly well-established practice for ultrasound-guided regional anesthesia and also look a little bit more to the future, some of the newer technologies and techniques that have come along. First, I need to tell you my disclosure. I receive equipment support for research and honorarium and also sit on the medical advisory board, but none of these involvements will affect my presentation. So here again, I'm talking about another gadget. A gadget, anesthesiologists love toys, and we love toys. Ultrasound is another toy that we can use. I think what we do recognize is ultrasound is a very powerful tool. We use it for regional anesthesia for a number of reasons. First of all, it allows us to see the nerve, right? We have to recognize nerve structures as well as non-neural structures such as pleura, muscles, vessels, and it allows us to see the needle. The needle, obviously, there's an in-plane technique. You can see the needle very well. We can appreciate the interaction between the needle and the nerve, and most important of all, we see the local anesthetic spread, because ultimately it's local anesthetic spread that determines the block success. It is not the needle. And what is wonderful about ultrasound is we can move the needle in any way we want during injections to make sure if the local anesthetic spread is not good enough, we have a second chance. I think those are really the advantages of using ultrasound. I recognize that ultrasound is not available in every institution. It takes us quite a long time to establish that practice. So first of all, yes, we need the equipment. Otherwise, that's not going to help you. I think there's very little doubt now to show that ultrasound is more reliable than nerve stimulation. Ultrasound machines are expensive. It's more expensive than my car. When we first talk about ultrasound, people will laugh at us because nerve stimulation is so much less expensive. But as far as nerve localization is concerned, ultrasound is clearly better. There are many, many meta-analyses, systematic reviews comparing the nerve stimulation with ultrasound, and there's clearly no question. I think the debate is over. Ultrasound can improve the accuracy of nerve localization compared to other nerve localization methods. It can improve block success rate. We don't really worry so much about block success anymore. It's not 50% success rate. It certainly can decrease the local anesthetic requirement because of the improved accuracy. And finally, it can definitely decrease the incidence of accidental vascular puncture. So those are the advantages. But more important than that, I think ultrasound has leveled the playing field. We are not talking about just a few individuals in every institution to be the special anesthesiologists who can perform regional anesthesia. Many, many people now, because of ultrasound, because they can see where the nerves are, they are able to do it. I think this really has expanded the practice of regional anesthesia. To me, that is really a big change in our practice. But I don't want you to leave here with the thought that ultrasound is everything. Ultrasound is just like a piece of equipment, a piece of instrument. If we do not learn well how to master the technique, how to use the equipment properly, we are not going to have good success. We are not going to have good patient outcome. So I really encourage you to think of it that way. So training is very, very important. And ultrasound has limitations. So when we talk about ultrasound-guided regional anesthesia, it is not just a technical skill, right? We have to use our brain. You heard from the first lecturer about the knowledge and the wisdom. We need to apply the same thing for ultrasound-guided regional anesthesia. It's more than a technical skill. We have to ask, is it indicated when we should do it, when we should not do it, and also recognize some of the complications. It is both, it has involved not just our hands, it involves our eye-hand coordination as our brain, because we need to interpret the images. We have to know what we're looking at. Yesterday I heard about the word pattern recognition, and that's true. It takes time to acquire that pattern recognition. What is a nerve, what is not a nerve? And also, we have to acquire the image. How do we scan in order to get the proper image? And finally, the technical skill. So all those things is a complete package. We cannot just think of one versus the other. I think what's very important is not that we should only look at the nerve. We have to see the needle, particularly the needle tip. Otherwise, it's actually more dangerous. You see the nerve, you keep poking at the nerve, and we don't even know the needle is poking at the nerve, and that actually will cause more injury. So again, I want you to have the impression that it's not so simple. We have to know what we do. What we really want to do is to get the needle as close to the nerve as possible so that it will improve block success, but close enough that we are not hurting the nerve, not too close to hurt the nerve. I think that is the ultimate goal. So what I've been talking the last few years is hydrolocation, hydrodissection. Hydrolocation simply is using a little bit of fluid injection. I want to see as a surrogate marker of where the needle tip is, particularly with the outer plane technique. Sometimes we cannot always see the needle tip, so that helps us to tell us where the needle tip is approximately. In the hydrodissection, again, using the fluid, we push the tissue away, dissect, just think of it like the surgeon's knife. We are going to use the tissue to expand the tissue plane and allow our needle to go forward. And every time I'm pushing the nerve away from the needle tip. So I really like that concept. In recent years, we know that it is important to put the local anesthetic around the nerve, not inside the nerve. So close enough, but not inside. And we call this the paraneural compartment. And for the sciatic nerve in the popliteal region, you can see it quite easily. It's not always easy to see this space because when we push the transducer on the patient and push very hard, we will narrow that space. So this space is really between the fascial plane of the surrounding the muscle and also between the epineurium of the nerve. So with hydrodissection method, we are hoping to localize this tissue plane. And what we are talking about here is this blue area, the perineal sheath that is on top of the nerve. It is like the underpants. It is right on top of the skin, as opposed to the muscle epimysium sheath of the muscle that is the outside. So we want to put it, the local anesthetic, very close to the nerve, but not inside the nerve. I think from success now, we don't talk a lot about success anymore because we are achieving very high success rate with ultrasound-guided regional anesthesia, particularly for upper limb block. Now we've shifted our focus to safety. How can we do better? I think a number of very good, large outcome registry, one by the Pittsburgh group, one by Dr. Sykes in Dartmouth group, and Dr. Michael Barrington's group, and they have demonstrated, yes, ultrasound has decreased the incidence of accidental intravascular injection and has decreased the local anesthetic systemic toxicity. And that is very little question that this is true. What it allows us to see is there are times you don't even want to get close to the nerve because this area is very vascular. So if that is the case, go to a different location to do the block. When we inject local anesthetic, we appreciate the expansion of the area where we inject. If you see the hypoechoic fluid collection here, that injection got to be extravascular. If it is intravascular, you would not see such fluid expansion. So this is important. And not just watch this at the beginning of the injection, but throughout the injection. That is very important. In that case, you will not get an intravascular injection. Areas in the neck, for example, interscalene block, the C7 nerve root is very close to the vertebral artery. Both of them are very dark. Again, use Doppler, color Doppler with the ultrasound to help you to differentiate. You don't want to get your needle and injection in vertebral artery. But ultrasound has limitations for anything deep. When you don't see the needle tip well, when you don't see the local anesthetic spread, complications can still happen. So I want to caution you that ultrasound is not perfect. Next is intramural injection. We don't want the needle to be too close. In fact, the needle is now inside the nerve. How can we tell? With 1 or 2 mils of injection, you see the nerve swelled up. That is very clear. This is a cadaver study showing that even with a very low volume injection with the dye, they can appreciate the nerve expansion. So this is a very sensitive way of picking up intraneural injection. But we must image the right place. So for me now, when I do the injection, I would also scan proximally and distally away from the injection site to look at the spread of the local anesthetic as well as signs of intraneural injection. Because if you're only imaging in one place and if that's not correct, you will miss it. So what we do know is that when the nerve swells up, all it tells us is the fluid is injected inside within the epineurial sheath. But what we cannot tell with ultrasound whether the local anesthetic is injected inside the fascicle or outside the fascicle. All it tells us is it has penetrated the epineurium. Even with experts, with such low volume injection, can still miss the signs of intraneural injection. That is why I would use a bigger volume, 1 to 2 mil every time when I inject, and also I scan proximally and distally to check that I'm not missing. So how do we prevent intraneural injury now? For me, I like to do a perineal injection. If I do that, I aim at the periphery of the nerve. I don't point right at the center of the nerve. And also, I, again, love fluid. The fluid helped me to move the tissue away, and then as long as the needle is in this pool of fluid, I know that I am very safe. I am not hurting the nerve. So this is not evidence-based. This I'm sharing with you my clinical experience. I think this helps me by avoiding nerve injury. I again do a hydrodissection method. I always like fluid stay in front of the needle. During this dissection, I advance the needle and I target the nerve at the periphery. Once I've created fluid collection, then I can move my needle around the nerve without touching the nerve. And then I like to see the needle tip as I inject so that I know whether it is inside or outside the nerve, and I scan proximally and distally in order to check for signs of nerve swelling. So I find those are helpful for me. I like to share with you and my experience and see whether that would help you too. There are now obviously too many topics to cover. For upper limb blocks, I'm just like to focus a few things on interscaling block because recently there are a lot of publications on interscaling block. Functional deficits can still happen. Why? With ultrasound, because again, it's operator error. When we inject, we may not see the nerve swelled up. In this case, it's only afterwards the operator recognizes. So again, I encourage you to scan proximally and distally to check. So my personal experience is I said, first of all, I look at the nerve roots. I can tell where they are. So now I like to do a compartment block. I want to put the needle in between the nerve roots and then I inject. So either inside the interscaling groove or another technique approach that Dr. Sykes' group has advocated is the Plexus technique. What it really means is that when the needle has gone through the middle scalene muscle, approaching the fascia plane of the middle scalene, you start to inject, and you want to see whether local anesthetic will spread into the interscaling groove or not. Sometimes you can, sometimes you cannot. If the fascia sheath is very tough, you really have to puncture it. But there are times that you can. And this is one example. As the needle is going through, I started to hydrodissect. I look for the local anesthetic spread, whether it goes inside the groove or not. If it does, that's all I want. I like as long as the local anesthetic goes into the groove, I'm happy. I don't need to chase after the nerve. Also, at the same time, I see the needle tip all the time within the fluid, pocket of fluid. I know that is very safe. I'm not touching the nerve roots. Another thing we talk a lot about is the phrenic nerve, right? We are obsessed with the phrenic nerve. It's true that occasionally patients become symptomatic. They cannot breathe. And we do know that the phrenic nerve can be very close to the brachial plexus C5 nerve root at the level of the cricoid cartilage. As you scan further down, the phrenic nerve is going to travel medially. So the approach now is to use a smaller volume, as little as 5 mils in this study, and also the next strategy is to do the block lower down at C7 nerve root level. By doing both smaller volume and a lower level block, you hopefully can avoid the phrenic. But what ultrasound can give us further is not just guiding the needle. We can use ultrasound as a diagnostic tool. So I'm sure you can learn, I can learn. We can look at the diaphragm. The diaphragm on the right side is very easy to see because the ultrasound goes through the liver. The left side is more difficult because the fundus of the stomach is full of air, so you have to move the probe more posteriorly. The diaphragm is a very clear, bright structure. As the patient take a deep breath, you see the diaphragm descend on both sides, so you can do a qualitative assessment. Or you can also use M mode, use a quantitative assessment. You can see the excursion of the diaphragm by asking the patient to take a deep breath, or ask the patient to sniff. When you ask the patient to sniff, you will see these deflections. So again, it's a very quantitative assessment. And this is after the block, very quickly. Within 5 minutes, the sniff test is flat, so you know the diaphragm is blocked. So I think with time, we can use ultrasound to also check for diaphragmatic paresis. A recent study looked at supra versus infraclavicular block, and even with a big volume, supraclavicular block have more than 30% of the phrenic nerve blockade. So this is, even with a big volume, low down, supraclavicular area still have a big high incidence. So we have been experimenting, trying a different approach. Again, go low, supraclavicular area, just get to the superior trunk, consisting of C5, C6 nerve root, and we use up to about 12, 10 to 15 mils. And we know by that time, the phrenic nerve is already medial, and by limiting the volume at a low location, we are able, this is just a case study, we're able to spare the diaphragm blockade. So this is something I think worthwhile to try out. Two other blocks that people talk about is the suprascapular nerve and the axillary nerve block in someone you really worry about the respiratory function. But in my hand, with these two blocks, is only good for closed procedure, shoulder procedure, arthroscopic surgery, and it's not for open. And the degree of analgesia will never match the interscalene, the brachial plexus approach, in my opinion. So a little bit about supraclavicular block. We do a lot of supraclavicular block now. We call it spinal, Dr. Sykes called it spinal or brachial plexus block. Yes, it's very useful because the trunks and the divisions are packed together. We talk about the corner pocket, put the local anesthetic between the subclavian artery and the first rib. And the reason of doing this is if this is for hand surgery, you need to block the inferior trunk. Again, I have changed my practice. I've changed my practice again using the hydrodissection along the way. With this block, it's easy to see the nerve, but you always, again, have to look at the needle tip. This is important. Using the fluid will, again, help you to locate the needle tip. And also when you dissect, you can see the fluid expansion. Once it's expanded, you can dissect your way down to the inferior trunk. Conceptually, I think it makes more sense, and I am happy I've been using this for quite some time. Ultrasound can also tell you whether not just the stimulation is good, but whether the spread is inside, within the sheath or not. And if you see this spread, this local anesthetic is spreading away from the plexus. So that's not good. In fact, I have to push in the needle a little bit more in order to get to the plexus and now I get to a good spread pattern. So recognizing local anesthetic spread pattern is very important with ultrasound. Dr. Barrington's group also have warned us about pneumothorax. It has not happened often, but periodically in our institution, we must have done more than 5,000. We have one case. It happens. So we have to pay attention to the technique we insert the needle. Again, looking for the needle tip is very important. How to move the probe properly, hold the probe properly to scan. Again, use ultrasound. If there is a concern about pneumothorax, use ultrasound to diagnose it, the pleural sliding sign versus there is no sliding with pneumothorax. Again, with the M mode, it's very clear. The granular pattern that you see for normal is now replaced with the barcode sign. So again, using ultrasound, you look at the B lines, looking at the lung pulse, looking at the lung point. They are all very helpful signs to tell you whether there's a pneumothorax or not. Next, I'd like to move a little bit now to talk about the lower limb, adductor canal block. There are so many studies looking at adductor canal block. It blocks not only the saphenous, but hopefully the part of the obturator nerve and also some of the smaller nerves of the knee. And looking at the analgesic effect, it shows a number of studies show that it's just as good as femoral nerve block for total knee replacement without the quadricep weakness. So for our institution, we already have changed our practice. We switch. We don't do femoral nerve block anymore. But when we do this block, it's important to pay attention to the two linings. You see a very bright line here, the fascial plane of the sartorius muscle. The other bright line is the vasto-adductor membrane. And when the needle goes through, make sure that it is not just through the first layer. It has to also puncture the vasto-adductor membrane in order to achieve a perivascular injection technique. So that's important. Another number of reports and editorial letters to the editor talk about where exactly the adductor canal is. I think a lot of people think that when we use ultrasound to trace the femoral artery once it crosses, laying below the sartorius muscle, it is already adductor canal. In fact, anatomically, that's not true because this is only the beginning of the femoral triangle. The definition of the adductor canal is when the medial border of the sartorius muscle meets the medial border of the adductor longus muscle. This is where the adductor canal meet. I think the concern is if we're using a big volume of injection too high up, we still can get quadricep weakness. So this is something that we should pay attention to. You don't want to inject too high up in the adductor canal. So it's very useful, it's very easy to do, but then unfortunately the dose response is no one can really do that because it is not always achieve a sensory anesthesia in the knee. Another block that I think is very helpful for all of us, if we are doing ankle block, we do ankle block for a lot of toe and foot procedures. One that we have changed our practice is the superficial perineal nerve block. Instead of doing just a ring block, to block the subcutaneous branches of the superficial perineal nerve, and we know that is important because it covers the dorsum of the foot. It is not so easy to do this ring block in someone with such a swollen ankle, and I have tried 3 times, and I still fail because I don't know where these branches are. So instead, go high up, go up into the leg, and this is where you will see the superficial perineal nerve as a distinct nerve. It's very clear, very superficial. Anteriorly, you see the anterior muscles, the extensor digitorum longus muscle, and posteriorly is the peroneus brevis and longus, and you see this bone, that's the fibula. So my fellows taught me this is the finger pointing at the nerve, that's where the superficial perineal nerve is. So it's a very easy block to do and also very consistent. So something that we should all do it, particularly in someone with a swollen ankle, is not as painful when you do the infiltration with this technique than the infiltration technique. So it's a very easy superficial block to do. So what about the future? I think there are a number of things that we talk about. I believe that instead of always look outward, we should look inward. Outward is we always chase after the best technology. What is the next in things coming? The ultrasound machine, and there are so many of them on the market. I think we should look inward because I want to emphasize training. That's why you are here, I'm here, because we need to be better with what we do. And again, ultrasound-guided regional anesthesia is not just a technical skill. We also have to combine with cognitive skills. I think we should have a better curriculum. I think we should have training. We should also pay more attention to assessment. I think many of us, after we have attending a course, we feel energized, we feel that we are ready to go. But the question is, are we ready? Are we good enough? Talking about curriculum, a few years ago, I was also part of this in drafting an education and training document. This is the first document. I think it's time to revise it. In this document, we talk about the scope of practice, we talk about the type of blocks we do, and we just list them out. I think at this time, we should be more precise. We should divide it into different level of complexity. Some blocks are very easy to do, and it would take you no more than 10, 15 to master the skill, but some are much deeper blocks to do and much more challenging. I think we should now divide it into basic, intermediate, advanced, and for each block, we can maybe come up with 10 essential things that we should learn from each block. The other thing I hope we will learn is from the ACLS course, why do we have a different curriculum for different conferences and workshops? I hope later on we'll have one standardized curriculum for everybody, just like the ACLS course. That's my dream. Next is, in North America, we are switching to competency-based education, not time-based. Not every resident has to finish the residency in 4 years. It's competency-based because we have to assess their competency level. So this is what I took from the group in Ohio, and they talk about interactive assessment. I think it's important in order to really check our competency level. We have to have some kind of exam, like the OSCE and the OSAT, and we learned that. We learned that from our surgical colleagues for technical skills. They have a workshop station. They have asked oral questions as well as ask the examinees to demonstrate how they do things. And I took this from the Israel group. They have the Israel National Board examination, and they have the OSCE to look at anesthesia skills. In this case, regional anesthesia skills. It takes work. It takes a lot of effort to set this up to test, but I think it's a very good model. If we have time, I think we should try to do that. Another thing I see coming, I know some of us are still struggling to have our first ultrasound machine, but in the future, I believe this is going to come is all of us is going to throw away our stethoscope and replace with a hopefully affordable ultrasound machine. And this is obviously something that you have in your pocket, your smartphone and your iPod, and it's coming. Because this is no conflict of interest, because on the market there's only one pocket-sized ultrasound machine is by the GE group. They developed this before for echo, transthoracic echo, but now they also come up with a dual scan. It's a linear probe. So recently I tried it out. The resolution is not perfect yet, but I hope that with time it's going to be as good. The image quality at this time is like what I saw in the mid-2000 time. The resolution is only up to 8 megahertz. But yes, for infraclavicular block, I can see the nerve quite well. I can see the axillary artery. I do have a little bit of a difficult time seeing the needle tip, but all those are possible things to do. So I hope that with time, we will have our own ultrasound machine. And I hope that ultrasound companies would be able to, we follow the model of the smartphone, all of us will be able to use one. And also other companies will come up with tablets. So I hope I have emphasized during this lecture the success. Yes, ultrasound can improve our success rate. So for those people who are skeptical, I encourage you to learn the technique, to really test it out. It's not just looking at what randomized controlled trials tell you, but your personal experience is the most important. If it works in your hand, that makes the big difference. Safety issues, we are not completely safe with ultrasound guided region anesthesia. We have to pay attention to how to do our block with hydrodissection, hopefully would help us to improve the success rate as well as the safety. Aim to put the local anesthetic around the nerve and not inside the nerve. For interscaling block, think about using a low dose, a lower block technique in order to avoid the phrenic nerve. For supraclavicular block, look for the needle tip. It's very important. Track it all the time. Some of the newer techniques that we are learning to do, adductor canal block is simple to do. Superficial perineal block also simple. And emphasize on training and how to assess competency, particularly if you are a teacher, you want to put emphasis on that. And hopefully, in the future, we all have our own ultrasound machine for different purposes. Thank you very much for your attention.